Donald, and I'll be presenting to you guys on spondylolysis. So just to start off with some of the prevalence of this in high-risk athletes, this occurs 6 to 11.5% of the time with low back injuries, and in general populations, this is fairly common as well with 3 to 7%. Some of the high-risk sports that you would see this occurring would be gymnastics, football, and snowboarding would be an extreme sport that you could see it as well. Just to start off, again, the etiology, the definition of this is a defect of the pars or articularis of the lumbar spine. It's also known as a Scotty dog fracture, as you can see right here. Kind of looks like a Scotty dog, big head and small body, and the fracture is supposed to be kind of like the dog's collar. It's extremely common in sports that require excessive lumbar extension, though these can also thought to be hereditary as well. This is due to the different structures that occur with hereditary. If you're larger, if you have decreased range of motion, maybe your pars interarticularis is smaller. There's a lot of things that can go into it. It also most commonly affects the L4 and L5. L4 a little bit, quite a bit less, between 5 and 23%, and it'll affect the L5 between 71 and 95% of the time. So some of the signs and symptoms of this are low back pain. That's the most common. It also worsens with activity, and if you do any kind of lumbar extension, it gets the symptoms are exacerbated. You can also get some radiculopathy with, in extreme cases, more common signs and symptoms are muscle rigidity and guarding. You'll also see them walking with an altered gait, and they're also very unwilling to stand up straight, just put their shoulders back and kind of present themselves. But often the only symptom that they present with is low back pain. So a couple of special tests that we use in the athletic training room is the sprint test. The specificity and sensitivity of this were not reported, but when you do it, you press posterior to anterior on the spinous process, and they would get increased pain with the affected vertebra that you're pressing on. A test that's actually designed to try and indicate spondylolysis is the stork standing. The implication of this is you might have a unilateral fracture with pain on the opposite side of your stance leg, so on the contralateral side. And this is due to the muscles activating, so your iliopsoas, so if you're standing on your left, your right iliopsoas will be firing, pulling that vertebral body forward and the spinous process back. And if it's bilateral, you would have pain on both sides. You always want to make sure you test both just to rule out that they have a bilateral fracture. The specificity of this was 17.2%, and sensitivity is 73%. And if you get positive with both these tests, that would indicate referral. And some of the imaging tests would be X-ray and a SPECT scan. So an X-ray, as you all know, is just a radiography. It's typically the first method of trying to diagnose a spondylolysis. It can be taken anterior, posterior, posterior to anterior, sagittal, and oblique. However, this method is not very good. You very often go and get false negatives, and it's only 30 to 38% effective. And most often you see the defect with the oblique. So this would be just like it says, the lateral. And the oblique is kind of when you rotate slightly and try and just take a picture directly onto that pars interarticularis. So a SPECT scan is, the long name of it is a single photon emission computed tomography. It's a nuclear imaging test that uses radioactive dye and a special camera to create 3D images of the affected structures. It's very similar to a bone scan. So when they inject the dye, they will take the image, and if you can see that extra dark spot, that would be the area that's would be known as a hot zone. So it's doing a lot of repair, there's a lot of tissue irritation right there. It's a very good test, it's sensitive at 76.8% of the time, it's very specific to it as well at 83.9% of the time. However, it is fairly expensive, and it's not commonly found in clinics as well, which is why the x-ray is typically used first. So conservative treatment of this is the first line of treating it, and you'll be placed in a lumbosacral orthosis, which is what that is. And what it does is it prevents you from rotating, extending, or flexing. And you'll be in that for up to 6 months. And the only time you would take it off is for rehabilitation or to undergo your daily hygiene. And success rate of this is fairly high at 83.9% of the time. It's a lot higher with unilateral, but not with bilateral. When you have a bilateral spondylolysis, you typically resort to surgical intervention. And indications for surgical treatment is 6 months of activity modification or the conservative treatment, so your general strengthening of the core, stability of the core, working on range of motion and performing your sport-specific activities in a pain-free manner. If all those are ineffective after 6 months, then surgical treatment would be indicated. But before you even choose a treatment, you need to make sure that you choose the right physician for you. You need to choose a physician that's familiar with the method that you need. You need to choose the procedure that is specific to fixing your specific defect. And you also need to choose a procedure based on the patient's anatomical individuality. So there are different procedures based off of your activity level, your age, your gender even. The Buck's method here is probably one of the most common methods. It's when you take a cortical screw and you go straight across. So you can see here the defect, it's not separating where you would with the spondylolisthesis. But you take those 2 cortical screws and depending on where the fracture is, you determine the size of the screw, the diameter of the screws based on the size of the patient. And you go perpendicular across that defect. And once that's in, they go and take calcaneus bone from your posterior iliac spine and put a bone graft over the screw. And you also go and put the calcaneus bone in the defect as well to go and try and cause some osseous healing. And this has a 72-78% success rate as well. It's fairly good surgical method. With conservative treatment and surgical treatment, you're going to undergo pharmacological interventions as well. So you'll be given some analgesics to control pain. You could also be given some NSAIDs to go and control some inflammation and pain as well. But typically, if you're doing conservative treatment, you will just be prescribed some over-the-counter NSAIDs to try and control pain. If you undergo surgical intervention, that's when you would be prescribed some analgesics. So the rehabilitation part, following surgical repair, you're allowed to ambulate the first day after operative treatment. The day of the treatment, you're bedridden, they want you to rest, and your walking is limited. You'll only be allowed to walk until you start getting sore, and then they'll want you to rest. And it's for short spouts too. You also have to wear the lumbosacral orthosis for 6 weeks post-operatively or until osseous healing has occurred. And once the osseous healing has occurred, the same thing occurs as with surgery. You go underscore core strengthening and stabilization exercises, work on range of motion, pain-free range of motion, and then slowly progression back to functional activities. So the return to play guidelines are they must have pain-free range of motion, they have to have adequate core strength and stability required by their sport, they have to be able to perform sport-specific activities within the sport without any pain, and again, asymptomatic and full fusion of the defect, and that's determined through the x-ray and a SPECT scan. So in summary, we went over the etiology, some of the signs and symptoms, special tests, diagnostic imaging treatments, and the return to play guidelines of the spondylolysis. And references, any questions?